All right. Hello, everyone, and thanks for joining our 2024 ICD-10-CM Updates and Regulatory Readiness webinar. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded and will be available to you along with a slide deck and a certificate of attendance for those who are here today. Throughout the session, all attendees will be in listen-only mode. At the end of the webinar, we'll do a Q&A session, but if for any reason your question is not asked or responded to, we will address it after the webinar. So go ahead and put your questions into the question section on your Zoom panel. We like to keep things interactive, so for those attending, we will be launching poll questions for you to answer. Today, we have three presenters from IMO: June Bronert, she's our Senior Vice President of Global Clinical Services; Teresa Rehanick, Mapping Informaticist; and lastly, Dr. Julie Glasgow, she's our Senior Clinical Terminologist. With all of this being said, I'm going to pass it over to Teresa.
Thanks, Jordan, and I'd like to welcome you all to our webinar today. It's important to maintain the terminology and the associated code mappings within your data to assure that those current codes are available for use. And this not only helps you to prevent reimbursement issues such as denial or claim delays, but ensures that your data is correct for the date of service. IMO supports our clients by doing that maintenance through the update of code sets. So let's get started and look at what's changed in ICD-10-CM. So today we're going to cover the additions and revisions of ICD-10-CM. We'll also look to a couple of ICD-10 guidelines that I want to point out. We'll highlight some changes within the index and tabular. And at the end of the presentation, June will take a look at what IMO is doing to support HCC version 28, and Dr. Julie Glasgow will look at our ICD-10 modifier changes. This was the third regular update of ICD-10-CM effective on April 1st. So taking a quick look back, there were about 40 new codes related to social determinants of health that were added for the 1st of April this year. And everyone is usually interested in what the numbers are. How many codes do we have right now? With the October 1st update, we'll have 74,044 codes. On average, they implement about 500 new codes each year. And for 2024, this is somewhat of a lighter year because we only have 395 additions. Deletions were 25 and revised titles were 13. In the infectious disease chapter, we have codes related to Acinetobacter baumannii, which is a gram-negative bacteria that can cause infections in the blood, the urinary tract, the lungs, or in wounds, and it can also colonize. Antibiotic resistance is common with Acinetobacter baumannii, and carbapenem resistance is also a challenging issue. So as you can see, we have a new code to reflect sepsis, and then you can use the B9683 as a supplemental code if you had a patient with UTI due to Acinetobacter. We also have a new code in the respiratory chapter where J1561 represents pneumonia, and then they rounded out that category so we can capture other gram-negative bacteria pneumonias. We have a new code for resistance to carbapenem, and then you can see several new codes on the right hand of your screen to capture a variety of carrier states for carrier of resistant carbapenem resistant or sensitive Acinetobacter baumannii, and then they added Z2235 to capture whether patients are carrier of Enterobacterialis, which includes both E. coli and Klebsiella pneumoniae, and then the specific whether they're carbapenem resistant or not. I wanted to highlight the COVID-19 screening guideline. It has been updated to reflect that we are no longer in an emergency state for the pandemic. So this includes preoperative testing, and so we're supposed to assign Z1152 when patients come in for screening in absence of any symptoms. We also have new codes in the neoplasm chapter related to desmoid tumors. These are a rare type of tumors that arise in the deep connective and soft tissue that often have a variable and unpredictable course. Desmoid tumors do not metastasize, so they're not classified as malignant tumors, but they are locally aggressive, infiltrative, and destruction, such that that condition is also known as aggressive fibromatosis. It most frequently is seen in patients that are between the ages of 10 to 40, and it is more prevalent in women. The tabular identifies the D4811 as a subcategory specific for desmoid tumor codes, and there's quite a few codes within there to capture various sites. And then D4819 is for all other neoplasms of uncertain behavior that would fall in that section. I did want to point out desmoid tumor is also known as aggressive fibromatosis, and the indexing for aggressive fibromatosis directs you to write code at D481, but you have to know that it's a synonym to correctly assign it a desmoid tumor. Right now, there's not an inclusion note in the index, and IMO has asked the committee to consider whether they would add that in. Familial adenomatous polyposis. This is an inherited disorder that predisposes one to colon cancer, and there's also a development of a large number of colon polyps. There's 3 types of FAP: classic, attenuated, and autosomal recessive. The classic and attenuated types are caused by mutations in the APC gene, while the autosomal recessive type is caused by a mutation in the MUTYH gene. In classical FAP, patients develop multiple colon polyps while they're teenagers, and then without a colectomy, those polyps are expected to become malignant, and the average age for colon cancer to develop in the classic FAP is 39. An attenuated FAP polyp growth is delayed, and the average age of colorectal cancer development is around 55 years. So to appropriately report a familial adenomatous polyposis diagnosis, you'll need to assign D1391, and you see that there's an instructional note from my little tabular excerpt to code also whether those are benign or malignant. I did want to highlight that the indexing looks a little bit confusing right now. If you see polyposis coli, adenomatous is a non-essential modifier directing to D12.6. The same thing is present with the subterm for colon, but then under intestinal, they broke out adenomatous and directed it to D1391. We've asked the committee whether they wanted to make some adjustments in that, if the adenomatous actually should not be a non-essential modifier at coli and colon, and correct the indexing. Related to polyps, we have several new codes for family history of colon polyps. So you can see they classify the different types of colon polyps. So we're going to do a poll question now. We have a 53-year-old male admitted for diagnostic colonoscopy. Polyps were identified and removed. The pathology revealed benign polyps in the colon and familial adenomatous polyposis. So, Jordan, can you please launch the poll? And these are the questions with the codes. So let us know what you think.
All right, we'll give it a few more seconds while people respond.
Got a good answer, Jordan?
Yes. So it looks like a kind of an even split between A and B.
So the correct answer is B, because if you have familial adenomatous polyposis diagnosed, you code that, but the pathology also indicated that the polyps were benign. So you would apply D1391 and D12.6. So moving on, sickle cell dactylitis, we have new codes to represent that complication of sickle cell disease within those codes that you see here on the screen. I wasn't sure what dactylitis was when I first heard about it, but it's a severe inflammation of the fingers and toes that's commonly seen in infants with sickle cell anemia. And often that might be the only clinical indication of that infant being in a vaso-occlusive pain crisis. So early recognition of dactylitis can help prevent later complications of sickle cell disease. Vaso-occlusive crisis here is one of the most frequent reasons for inpatient care, and documentation for patients with sickle cell disease does not always describe pain crisis as a vaso-occlusive pain. So clinically, pain in a patient treated for sickle cell disease is vaso-occlusive. So they've made a change to align with that, where the vaso-occlusive is no longer a subterm, but it's been changed to a non-essential modifier in both the index and the tabular. So it'll be easier to get to if you only have pain documented with a sickle cell crisis. Schwachman-Diamond syndrome is another new code that is a multi-system disorder characterized by bone marrow failure, exocrine pancreatic dysfunction, and a predisposition to myeloid malignancies. In the tabular at D6102, there's instructional notes to code also those associated conditions like exocrine pancreatic dysfunction if the patients develop myelodysplastic syndrome or acute myeloid leukemia. At D8984, we have a new code for immunoglobulin G4 related disease, which is a recently characterized rare multifocal disease of unknown origin. It's a type of fibroinflammatory disorder. People with this disorder are generally responsive to treatment with glucocorticoids, and treatment testing has also shown that there's been some utility with rituximab to help reduce how many steroids they need to take. They wanted to capture these diseases to help shorten the time to diagnosis and treatment, and look at some other evidence for how better to treat it. In hypoparathyroidism, we have several new codes at E20.81. You can see we have autosomal dominant hypocalcemia. This is a genetic disorder of calcium metabolism that patients often suffer from muscle spasms, cramping, twitching. Calcium can build up, so they can develop kidney stones. They can also develop calculi in the brain. Other codes within this subcategory capture secondary hypoparathyroidism and disease classified elsewhere. So you'd use that as a supplemental code with a neoplasm or thalassemia. We also have a unique code for autoimmune hypoparathyroidism. In the metabolic chapter, we have several new codes. LAMP2 deficiency is also known as Danon disease, and this is one of the most aggressive cardiomyopathies. It's a multisystemic disorder. It involves the heart, skeletal muscle, central nervous system, and retina. It was originally classified as a glycogen storage disease, but it actually is a transport disorder. At E8881, this was expanded to capture unique codes for insulin resistance syndrome. We have type A and B insulin resistance syndromes, which belong to a group of extreme insulin resistance syndromes. So you can see that type A has its own code at E8811, and type B is classified at the 818. E88.A for wasting disease syndrome due to underlying condition is a new code to represent that involuntary ongoing loss of more than 10% body weight with reduction in muscle mass. They wanted to capture the severity of illness for patients with different underlying conditions that also have the wasting disease. Leukodystrophies, there have been quite a few new codes added specific for these. This is a complex group of diseases affecting the white matter of the brain. There have been over 400 genetically unique leukodystrophies reported over the past 10 years, but they're still individually rare. So we have several new codes to specify some of these unique genetic leukodystrophies with distinct clinical courses. As you can see, they are classified in both the metabolic chapter, which are the ones with the E codes, and then the nervous system chapter for the ones that begin with G codes. And I did want to highlight that G3180 is for leukodystrophy unspecified, so that's in there as well. In the mental health chapter, they did not add any new codes, but we did have some reclassification. Prolonged grief has been reclassified from an adjustment disorder to F4381, which is prolonged grief disorder, which was a new code that was added last year. And then for childhood schizophrenia, that has been reclassified from Asperger's syndrome to F20.9, which is unspecified schizophrenia. And then also undifferentiated chronic schizophrenia has been reclassified to F20.3, which is undifferentiated schizophrenia. So it makes sense. Parkinson's disease, we have several new codes here. I'm sure many of you are familiar with this. It's a neurodegenerative disease that presents with motor symptoms such as bradykinesia with muscle rigidity and tremor. Over 1 million people in the United States have Parkinson's disease, and treatment with Parkinson's primarily is use of levodopa to relieve those motor and non-motor symptoms. Patients often experience a narrowing duration of the effectiveness of the levodopa as the disease progresses, and so that leads to complications such as dyskinesias and fluctuations, which are also known as OFF syndromes. So a dyskinesia is the uncontrolled involuntary movement of the face, arms, or legs, and those off states represent symptoms like tremor, rigidity, bradykinesia, difficulty with speech. So further specifying the Parkinson's will helped provide some data to target the development of interventions to reduce that off time. So you can see that the codes, the subcategories are without dyskinesia and with dyskinesia, and then those codes are further subdivided about without mention and with mention of fluctuations, which are also off episodes. Then G20.C for Parkinsonism is an umbrella term, which refers to brain conditions that cause slow movement, rigidity, and tremors. Other neurological disorders that they've created codes for are MOG antibody disease, which is a demyelinating condition of the central nervous system. It's characterized by a single phase or relapsing course of neurologic dysfunction that doesn't meet the criteria for multiple sclerosis. These patients may have optic neuritis, transverse neuritis, brain or brainstem syndrome compatible with demyelination. We also have codes for Lafora body disease, which is also known as Lafora progressive myoclonic epilepsy. This is a neurodegenerative condition that results in the accumulation of abnormal glycogen aggregates called Lafora bodies in the brain, heart, and liver, and that creates a degeneration of a progressive degeneration of the nervous system, which results in a variety of seizures. There's also a rapid cognitive decline and gross and fine motor regression. So the symptoms of this disorder appear in late childhood or adolescence, and you can see that those codes are modeled the same way they are for other epilepsies, where we have not intractable and intractable, and we have with and without status epilepticus. We also have new codes for chronic migraine with aura. So the left-hand side is the new codes, but I also wanted to show you that we had G43.7 for chronic migraine without aura already existing. And these follow the similar pattern that we see in the migraine chapter with not intractable and with intractable, with or without status migrainosis. And so the definition of chronic migraine as stated by the International Classification of Headache Disorders is a headache that occurs on 15 or more days a month for more than 3 months, which on least 8 days a month the patient has features of a migraine headache. So that chronic headache definition includes both migraine with and without aura. An interesting index change for cerebrovascular accident that we wanted to bring your attention to is that they deleted cerebral as a subterm. And then related to cerebrovascular, they moved embolic and thrombolic into their own subterms. So when you have an embolic cerebrovascular accident documented, you should look through the tabular to see if you have documentation of what vessel, pre-cerebral or cerebral artery it's in to capture that specific information in the code rather than just defaulting to the unspecified code at I-63-9. They also added a subterm for chronic cerebrovascular accident. So this code directs to the personal history of TIA and cerebral infarction. And then we also have a subterm there for residual deficits. So if the patient has hemopharesis or something, you would still code the sequela code for that. In the eye disorders, we have some other codes related to sickle cell disease. They've created new codes to identify non-proliferative sickle cell retinopathy and proliferative retinopathy. And so the sickle cell retinopathy is characterized when those sickle-shaped blood cells get trapped in the small vessels of the eye, leading to that non-proliferative or proliferative retinopathy. We also have codes for extraocular muscle entrapment that have been expanded to capture which eye muscle gets trapped in a fracture line of the orbital floor. This affects the eye's movement, causing diplopia. That entrapment can lead to necrosis of the muscle, so it requires some surgical freeing of that muscle. There's 21 new codes in that section right there because they identify right, left, and unspecified laterality. And we also have a new subcategory to capture foreign body sensation of the eye. So that's just what it sounds like. You feel like something's rubbing against your eye. People with dry eyes or insufficient tear film may have the sensation, or it could be related to inflammation of the eyelids, so forth. So all these codes have laterality options within them. At the circulatory chapter, we have a new code for resistant hypertension at I1A.0. Resistant hypertension occurs when the patient's blood pressure remains above goal despite at least 3 antihypertensive medications of different drug classes. So you'll want to make sure that if you have resistant hypertension, you don't use it alone. There's an instructional note to code first the specific type of hypertension. So if you have somebody with benign hypertension and it's resistant, you should pick up the I-10 plus I-1A0. We also had expansion of codes related to supraventricular tachycardia. It was really expanded to capture I-4711 for the inappropriate sinus tachycardia. This is where a patient has a sinus heart rate greater than 100 beats per minute at rest with a mean 24-hour heart rate greater than 90 beats per minute. Patients are noticing palpitations. There's several underlying diseases that can cause this condition, but it's not completely understood. We also have 4 new codes related to coronary microvascular dysfunction. This is a condition that impacts the microvasculature of the heart by restricting microvascular flow and increasing microvascular resistance. So those arteries don't have plaque in them, but the damage is done to the inner walls of the blood vessels, decreasing blood flow to the heart. So many patients that have ischemia with non-obstructive coronary arteries or have an MI with non-obstructive coronary arteries have some associated pathology within the microvasculature. So I wanted to highlight this new guideline for the MI with coronary microvascular dysfunction. It basically just says, it gives you 3 synonyms basically for what you might see in documentation, where to take this code. So I wanted to highlight that and highlight that if you see MINOCA documented in your record, you would pick up the I-21.B. We had some code title revisions related to thoracoabdominal aortic aneurysm. Last year, these codes were introduced, but the codes themselves actually had the title of abdominal aortic aneurysm, so they've corrected that. In the respiratory chapter, we have new codes related to bronchiolitis obliterans syndrome, as well as chronic lung allograft dysfunction. BOS is characterized by an airflow limitation that's not reversible by using an inhaled bronchodilator. That can be due to an injury, whether that's due to an infection, autoimmune disease, but most often it's seen after a lung transplant or following an allogeneic hematopoietic stem cell transplant. BOS often appears after lung transplant as a manifestation of chronic lung allograft dysfunction, or it shows up after the stem cell as the pulmonary manifestation of chronic graft versus host disease. There's different clinical subtypes of chronic lung allograft dysfunction, which include bronchiolitis obliterans syndrome, restrictive allograft syndrome, and also mixed chronic lung allograft dysfunction. So you'll see with the new code J4A.0, that restrictive allograft syndrome, there's an instructional note to code also the bronchiolitis obliterans syndrome if applicable. And then at the J4A0, there's a note that if it's documented as mixed chronic lung allograft dysfunction, you would also want to pick up, you'd code the J4A0 and add J44.A1 with it. And you'll see that, and as my example here shows, there's lots of instructional notes to pick up the transplant and so forth and any other conditions that exist. So you'll want to pay attention to those if you have to code this. I also wanted to highlight that J4489 was created to round out that category, and that's other specified COPD. And so because of that, we have several conditions that have been reclassified for various forms of COPD. Previously, these terms, these diagnoses were classified to unspecified COPD, and now they're going to be specified. So there's a lot of changes within the index, and these are kind of common things that you might see in a chart. And I also wanted to highlight out the chronic respiratory conditions at J68.4 that they've removed the inclusion notes under here for emphysema, obliterative bronchiolitis, and pulmonary fibrosis, and really turned them into code also notes. So they want you to pick up which condition it is. However, there might have been an oversight that the excludes one at emphysema still is there to exclude J68.4. So we've asked the committee if they would take a look at that to remove that exclusion so people don't get edits if they want to report that together. And the same thing happened at the pulmonary fibrosis entry. So just a little interesting information. I'm going to turn it over to June now to take us through the rest of the code changes.
Thank you, Teresa. Let's continue our discussion by looking at acute appendicitis. Appendicitis can present with peritonitis in different ways. When appendicitis leads to a perforation, it typically causes peritonitis. A frank perforation or rupture generally causes severe peritonitis, commonly stated as generalized peritonitis. It is also possible for appendicitis to be present with generalized peritonitis without a perforation or rupture of the appendix. Therefore, new codes have been introduced to capture the various situations at K35.20 and K35.21 as seen on the slide. Continuing on with digestive disorders, we will look next at intestinal microbial overgrowth. Intestinal microbial overgrowth results from overpopulation of bacteria, pathogens, or fungi in the intestines. There are different diseases which include small intestinal bacterial overgrowth, SIBO, intestinal pathogen overgrowth, and small intestinal fungal overgrowth, or SIFO. As you may expect, overgrowth diseases carry a variety of digestive symptoms such as bloating, abdominal pain, constipation, diarrhea, and so forth. SIBO is diagnosed via small bowel aspiration or breath test. Antibiotics are used to treat the small intestinal bacterial overgrowth. The new codes are further subdivided to 7 characters to identify subtypes along with an unspecified type. Small intestinal fungal overgrowth is diagnosed via small bowel aspiration and fungal cultures. An antifungal therapy is selected based upon the culture and sensitivity results. Pathogens are not bacteria. The gut is producing methane, and the severity of symptoms is related to the amount of methane being produced. Other digestive changes include retroperitoneal fibrosis is now classified to K68.2. A retroperitoneal hemorrhage has been reclassified from R58, unspecified hemorrhage, to new code K68.3, retroperitoneal hematoma. The last digestive topic we will review is short bowel syndrome. Short bowel syndrome, or SBS, occurs when a patient does not have enough small intestine to absorb nutrients from their food. The absence of the small intestine is typically from a physical absence or loss of a considerable portion greater than 200 centimeters of the small intestine. In SBS, the colon assumes a greater role than normal with regards to fluid and nutrient absorption. New codes have been created to specifically identify the state of the short bowel in association with the colon. SBS with colon in continuity means that the colon has been anastomosed to the residual small bowel. SBS without colon in continuity either means that all of the colon has been resected or the colon is not in continuity with the residual small bowel. For example, a patient with SBS also presents with an existing ileostomy or a jejunostomy or even a jejune ileorectal anastomosis. This would represent SBS without colon in continuity. Another code that will be implemented on 10-1 is K90.83 for intestinal failure. Intestinal failure is where the patient has the inability to absorb enough nutrients and/or fluid necessary to maintain nutritional autonomy. Many patients with SBS will also develop intestinal failure, so both codes can be assigned together. Turning our attention to the musculoskeletal changes, we will next look at reclassification of pelvic bone diseases. ICD-10-CM previously could not adequately represent an osteoporotic pathological fracture of the pelvis. These pathological fractures were currently assigned to M80.05 or M80.85, to which the code description was only specific to the femur instead of the pelvic bones. Typically within the musculoskeletal chapter, all conditions of the hip, pelvis, and femur are classified to the 5th character of 5. However, in this scenario, a new subcategory was created at M80.0B and M80.8B to specifically identify the pelvis for these disorders, rather than including these new codes in the subcategory of M80.05 or M80.85. There are around 34 new codes due to the capturing of the 7th character information related to the fracture. A considerable amount of reclassification was also done with respect to several other disorders affecting the ileum, ischium, and pubis ramus. The conditions listed above have been reclassified to the other site subcategory instead of the historical subcategory for pelvis and thigh. Moving on, there are code changes to nephropathy conditions. The immunoglobulin A nephropathy is the most common form of glomerulonephropathy. The condition is usually diagnosed when micro or macrohematuria is identified without any other cause. Proteinuria may also be present. 25% of patients with this type of nephropathy progress to end-stage renal disease or ESRD. Since the condition is commonly diagnosed in patients between the ages of 16 and 25, patients are relatively young if they develop ESRD. There are now 7 new codes in the subcategory of N02.B, which describe the specific types of this glomerulonephritis. Other nephropathy changes include new codes for membranous glomerulonephritis. Membranous nephropathy is a thickening of the renal glomerular basement membrane due to the immune system attacking it. Patients either present with nephrotic syndrome or a non-nephrotic proteinuria. Membranous nephropathy is diagnosed by a renal biopsy and/or blood test indicating the presence of specific antibodies. There are 2 subtypes of membranous nephropathy, which are primary and secondary. Primary membranous nephropathy is approximately 75 to 80% of the cases. In primary membranous nephropathy, the immune system is attacking cells known as podocytes. Secondary membranous nephropathy is caused by other autoimmune disorders like lupus, cancer, diabetes, adverse effects of medication, and others. New codes have been created at the respective subcategories of N04.2 and N06.2 to capture primary and secondary, as well as unspecified other types of membranous nephropathy. Next, we will look at obstetric disorders. Intrahepatic cholestasis of pregnancy, or ICP, is thought to be related to increased pregnancy hormones altering bile acid transport. The bile acid builds up in the maternal circulation and in the fetal amniotic fluid. It most often develops in the 2nd and 3rd trimester. The mother has a greater risk of preeclampsia and gestational diabetes. There may be a preterm birth and a risk of newborn respiratory distress, meconium staining, and even stillbirth. Mothers that have ICP are at risk long-term for other diseases like cholelithiasis, pancreatitis, and even hypothyroidism. New codes were established at subcategory O26.64. Subcategory O90.4 was further subdivided to separate anuria, oliguria, and hepatorenal syndrome from postpartum acute kidney failure. Anuria, which is the lack or absence of production of urine, and oliguria, which is low urine output, that are complicating the purpurium, will be classified to O90.49. Hepatorenal syndrome, which is decreased renal perfusion and decompensated liver disease following labor and delivery, has a new unique code also. The index has been updated to reflect these changes. Another index change is for entanglement of the umbilical cord. Entanglement of the umbilical cord around the neck no longer defaults to with compression. Now let's look at various congenital conditions. Q44.7, other congenital malformations of the liver, was expanded to specifically create a unique code for Alagille syndrome. This is a genetic disorder affecting the liver. Newborns often develop liver cholestasis, jaundice, and have pruritus. There are several new codes at Q75.0 to more specifically classify the type of craniosynostosis. Craniosynostosis is classified according to the cranial suture that is involved. There are codes to capture sagittal, corona, mectopic, and lambdoid sutures. Sagittal and mectopic sutures are midline sutures. Coronal and lambdoid sutures extend laterally on the skull. There are other types of craniosynostosis that involve multiple sutures. In cloverleaf skull, the sagittal, coronal, and lambdoid sutures close prematurely, resulting in a cranial content bulge that is in the shape of a cloverleaf. Pancytosis occurs when there is premature closure of 3 or more skull sutures. Earlier, Bardet-Biedl and Lawrence-Moon syndrome were grouped together due to similarities between these conditions. Similar characteristics included progressive blindness, obesity, and learning difficulties. There was a request to separate out these conditions, so 2 new codes have been created to identify them uniquely. New codes were also created for Med-13L syndrome, which is a genetic disorder due to which the patients have developmental delay, intellectual disability, and typically have unusual facial features. Phelan-McDermott syndrome is a genetic disorder due to defects in the long arm chromosome of 22. Now let's look at some of the changes to signs and symptom codes. Foreign body sensation in the throat has been classified to code R0989, other specified signs and symptoms involving the circulatory and respiratory system. With the introduction of these new codes, this condition will now be classified to a unique code as shown on the screen, R09.82. And later in the presentation, we will review external cause code changes related to foreign bodies, but next, let's look at non-traumatic coma codes. A new code for non-traumatic coma due to an underlying condition was introduced. This code is to be used when there is a known non-traumatic cause of coma, such as brain hemorrhage or brain infarction. Keep in mind that this code may not be necessary in other scenarios where the patient is in a coma, where the code describes the underlying condition and the associated coma, such as E10.11, type 1 diabetes mellitus with ketoacidosis with coma. The coma scale codes are not to be used with R40.2A per the coma coding guidelines, but there is not an excludes present in the tabular at this time. IMO has submitted a request for the committee to consider an excludes note in the tabular. We have a refresher of the coma coding guidelines on the next slide. And here's a quick refresher on the coma guidelines, which were updated to address the assignment of the code R40.2A. You can see where R40.20 should be assigned, and as noted a prior slide, not to assign the Glasgow Coma Scale codes with R40.2A. And now it is time for our second poll question. For poll question number 2, the 85-year-old female was admitted due to ischemic cerebral infarction, and she presented in a comatose state. Discharge diagnosis is ischemic cerebral infarction with coma. Jordan, can you please launch the poll?
Yeah, so if you could direct your attention to your screen, if the answer R40.2A, 163.40, and R40.20, 163.9, and R40.2A, and I63.9, and R40.2A. I'm going to give it a few seconds, and then you can close it out. All right, it looks like C is the winner there.
Great. The answer is C, I63.9 and R40.2A. The coma is due to the cerebral infarction. The code for cerebral infarction does not also identify the coma, so R40.2A should be assigned. And then codes from the Glasgow Coma Scale are not assigned per the coding guidelines. So great job, everyone. Continuing with changes to the R codes. There are several new codes that were introduced to capture very specific mammography density findings. The American College of Radiology developed the Breast Imaging Reporting and Data System, also known as BIRADS, to help interpret and report mammography findings. The 4 BIRAD categories of dense breasts are shown here on the slide. As you can see that the new codes align with the 4 categories, each subcategory of code provides laterality options as well. There is also a unique code for dense breast unspecified at R92.30. And recently, in March of 2023, as part of the FDA's updates related to oversights of mammograms, there are new requirements for notifying patients about their breast density. For additional information, a link to the FDA's website regarding this regulation is located in the resource slide. And so next we will review the new codes for gadolinium toxicity. Gadolinium is a heavy rare earth metal. It is used in many ways, including medical imaging, where it is a contrast agent for MRIs. It is also used in microwave applications, various optical elements, computer memory, along with data storage disks, as well as refrigeration and alloys to make magnets. Gadolinium toxicity can affect many body systems and present with various symptoms. There may be impairment of cognition and memory, along with sight, difficult swallowing, arrhythmias, disorders of gastrointestinal and urinary systems. A new code was created at T56.82 to capture gadolinium toxicity. Only 4 subcategory codes were created, and you will note that adverse effect of gadolinium is not included. There is an instructional excludes one that advises that the adverse effects of diagnostic agent is classified to T50.8X5. And so remember earlier in the presentation when I said we would look later at foreign body related external cause codes? Well, 123 new codes were added to ICD-10-CM with the addition of this category W44, foreign body entering into or through a natural orifice. These are to be used as supplemental codes with injury codes. And there are multiple codes under each code here, and each of those codes has a 7-character encounter type associated with it also. Chapter 21, Factors Influencing Health Status, also has new codes, especially as related to social determinants of health, as we will see next. This slide shows the various new SDOH codes. Z02.84 is to be used when a child is brought in by welfare or law enforcement for an examination unrelated to any abuse prior to placing the child outside of parental care. This may also be known as a medical clearance exam. With a variety of family dynamics, new codes are available to identify when a child is living with a step-parent or a non-parental guardian. These codes will help identify various issues related to upbringing and parent-child conflict situations that often contribute to a medical visit for the child. The Gravity Project, in conjunction with Veterans Administration, requested a new code to identify a history of military service as the risks of deployment and service are distinct. The new code Z91.85, Personal History of Military Service, and this can be used with the existing code Z91.82, Personal History of Military Deployment. There are also several new Z codes in Z91, Caregivers Noncompliance, which identify if the caregiver is noncompliant with the patient's medication, renal dialysis, or other medical treatments. Each subcategory provides a unique code for due to financial hardships or due to other reasons. And on the next slide, we will see other changes related to SDOH, and these codes are already present in ICD-10-CM, but there were some additions to the inclusion notes. You can see here the new inclusion notes identify where flat effect or loneliness, inadequate social support, at risk for loneliness, and increased risk for social isolation are now classified. The final Chapter 21 code changes we will review are related to observations and HIV. Z0581 was implemented to capture cases where a newborn who has a home monitoring device like an apnea or bradycardia device that is brought in for an examination due to an alarm from the monitor. In some cases, these monitors do create false positives where after the examination there is no clinical finding. This code will provide specificity around the reason for encounter where suspected conditions has been ruled out after the exam. Z29.81 encounter for HIV pre-exposure prophylactics was developed in order to capture encounters where pre-exposure prophylactics is provided. This medication is prescribed for patients at high risk for developing HIV through an intimate encounter or injection drug use. If this is taken as prescribed, it is very effective for preventing HIV. Next, we are going to take a few minutes to review IMO's support for HCC indicators. And as many of you know, the CMS risk model using hierarchical condition codes was significantly revised, necessitating a new version. CMS has titled the version 28 and implemented a 3-year transition period from version 24 to version 28. IMO realizes the importance of this change, especially during the transition period, and have many resources available to support you. We did want to highlight one resource, and that is the indicators associated with our terminology. And on the next slide, we will see an example of the indicators. We are starting with the sample problem list on the left-hand side of the screen, and next the IMO course sample problem list on the right-hand side of the screen shows the HCC indicator column. And as you can see, version 24 represents, or V24 represents version 24, while V28 reflects version 28. And if a term is part of both version 24 and version 28, the indicators are V24, and an 8. And while your specific EHR may look a little different from the IMO sample, IMO is providing the information to indicate both versions. And now I would like to turn the presentation over to Dr. Julie Glasgow.
Yeah, thank you very much, June. The very last section of this presentation is going over our calculator changes. And just to orient you completely, when we say calculator, you're talking about the prompts that IMO provides that help users get to a specific ICD-10-CM code. So in your system, these might be called modifiers or qualifiers. This is the list of all the changes we've made to our calculator content for the 2024 update. I'm not going to read through them all, but there were more than 20 diagnosis areas that were enhanced based on the new details added. I'll show some representative examples. Let's go ahead to the next slide. All right, so as previously mentioned, the coronary microvascular dysfunction is a new etiology that was added. There are actually 5 different diagnoses that now have this prompt in them. So this is just an example, coronary artery disease. There's that new value there. Yeah. Next slide. A couple of new details added for migraine. We've tried to make it clear the distinction between migraine and chronic migraine. And then we have the with aura and without aura choices now. And abdominal migraine has been added as a detail. The Parkinson's disease changes gone over earlier. Those have 2 whole new detail groups added. The dyskinesia and fluctuating manifestations, those apply only to Parkinson's disease. So we now prompt for those. And Acinetobacter baumannii, we added it as a pathogen to both pneumonia and sepsis calculators. Here is the new organism in our pneumonia calculator. For sepsis, as you might know, our sepsis calculator is pretty extensive, and the Acinetobacter baumannii detail does prompt for all of those same details as the other sepsis types. All right, proteinuria, all of those new diffuse membranous glomerulonephritis types are now prompted for. In a whole new group. Next slide. Then renal failure, the acute renal failure details have had those new details added for those perinatal conditions. And sickle cell, quite a few concept areas have had dactylitis details added. And here's an example. Our sickle cell retinopathy actually prompts not just for the new dactylitis detail, but also retinopathy details. So non-proliferative versus proliferative, and then the laterality. And next slide shows one of our two brand new calculator areas. Because craniosynostosis has so many details added, we went ahead and built out a calculator to capture the suture and then also laterality. And the very last calculator change is that dense breast tissue detail set of prompts. Again, those are required to be reported on all mammogram reports, regardless of the patient's actual breast density. There is a specific code now to capture whichever density they have. And so those are now available as prompts. All right, that concludes the modifiers section. I'll turn it back over to Jordan. Thank you very much.
Thanks so much, Julie. All right, at this time, we'll be kicking off our live Q&A. So if you had any questions coming in or this presentation spurred some questions, type them into your questions section on the bottom of your screen, and we'll start answering them. Just please excuse any brief silence while our team is looking at some questions. Okay, one question came in about, do we get CEU credits for this presentation? Like I said in the beginning, we will give you a copy of a certificate of attendance, and then you can send that to your professional association to see if this will qualify for getting extra credit. This question would be for you, June. Why is IMO support version 24 and 28?
Yeah, so there, as CMS has modified their version of HCCs to version 28, they did receive many comments between the time of the advanced notice and their final rule, stating that this change, there was the industry needed time for the transition. So in the final rules around the change of the version, CMS actually has a 3-year transitionary time frame of where both HCC versions 24 and 28 will be active. And so that is why that the indicators that IMO is going to provide with their content will identify version 24 ICD-10-CM codes and version 28 ICD-10-CM codes, and then identify if there is a code that is applicable in both versions. And that, again, that transition is for 3 years. It looks like we received a question around the COVID-19. There's some guidance since we are no longer considered the emergency of the pandemic as well. There's a question related to the release around SNOMED. On that one, I would suggest entering a ticket into our support case specifically for an additional detailed answer around the specific version of the release of SNOMED.
There's also a question about whether Z1152 replaces Z20.822, and no, it won't replace it. It's the screening code. You use the screening code now, and I believe Z2820. Just a minute, I'm looking it up real quick. I don't. Z20 point. Contact with and exposure to COVID. You wouldn't use that for a screening only. So like if a patient has symptoms, you could probably use it as a supplemental code, but you would use the Z1152 code first.
There's a question around resources related to coding and clinical criteria. I know there's a variety of professional organizations that have resources that support coding in primary care and other settings. And so that would recommend that you look to professional organizations to help support that. And if there's additional information that you're looking for to, around clinical criteria, then please let us know, because there's also the coding guidelines that are published as and updated routinely, along with coding clinic when it's related to ICD-10-CM, that also contains additional information that can help. A question around version 24 and 28 overlap. Will 2 ICD-10 codes be reported? The codes that would be reported would be the same for that patient encounter. The piece that will be of note, and that's why the indicator is if that diagnostic code is present in one system or one version or another version. There are some of the same ICD-10 codes that are part of both versions, and then there are some new codes that were added for version 28, and then some that will be taken away. So the codes will still be the same, and if a code is in both versions, then when it comes time to the details of calculating the risk score and translating that into payment, then that will happen based upon how much CMS has said is being reimbursed under version 24 versus being reimbursed under version 28, and make those detailed adjustments.
Thanks, June. I know a lot of questions came in about copy of the recording or the slides. Yes, be on the lookout in your follow-up email. Most likely tomorrow, I will send the certificate of attendance, the recording, and also a copy of the slide deck. It looks like our questions have winded down, so we're going to go ahead and close out today. We hope you found everything useful in today's session. And thank you ladies for all your hard work on this. I know it is a strenuous task. If you have anything related to customer support or any questions about the content of this webinar, please email customer support at imohealth.com. And then for anything sales related, please email your client executive or sales@imohealth.com. Thank you so much for tuning in, and we'll talk to you later.